This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with all the latest research that you can use in your addiction medicine practice. Also, remember that this podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME will be in the show notes. This week, we are going to be discussing an article about precipitated withdrawal. John, how are you doing tonight?
Doing great. Kind of in this nice interlude between Thanksgiving and Christmas. So my house has been decorated, although it's been that way since like the end of October. So
are you guys
very festive?
Christmas decorations all fall kind of people?
I'm not, but my wife and my children are. And I've just learned in time just not to fight it.
Yeah, definitely it's not a good look if you're fighting Christmas magic.
We had to abandon the live tree because if not, it was like this just dead black tree by Christmas because it's been up for so long. It was just sad Christmas morning with the elves. How about you, Sonya?
I'm doing well. We're the opposite. We always do our decorating and prep like really late. So I'm always like the person at the tree farm stuck with like the last tree that's either like really, really expensive or kind of deformed. So we have done no decorating yet.
You're like Charlie Brown.
Yeah, exactly. But it's okay. They have personality. So, John, anything catch your eye in addiction medicine news this week?
Yeah, I saw this update. It was from NIDA, and they have a section called Nora's blog, which is really interesting. It's like an addiction physician kind of talking about something in addiction medicine, and it was from November. And it basically was entitled Syringe Services for People Who Inject Drugs are an enormously effective but remain incredibly underutilized program. And I think that, it's interesting. We've talked about this before, that like public perception for syringe service programs has really improved, right? I think that compared to what it was in like the 90s, the overwhelming majority of Americans actually kind of embraced that idea. I don't have the statistic off the top of my head, but we did that one article before where actually the majority of the people felt that that was a positive thing. Yet we don't really use that. They're highly effective. In the United States, the rates are a little bit lower than Europe, but we've shown here that there's a 40 to 60% decrease in HIV and hepatitis C when these programs are available. They're often kind of very conveniently tied also to access to buprenorphine, fentanyl test strips, naloxone. So they actually end up with a way of like engaging this community. And despite the fact that we kind of over and over know that these are effective, we still just kind of have high level resistance to the use of these in many communities. And so the article just kind of basically went into the fact that like, despite, we have no evidence that there's increased crime, no evidence of increased kind of illicit criminal activity or improper disposal of syringes in the adjacent area. Still just kind of public perception. It's like not in my backyard, sort of like the nuclear power plants that people like it, but they just don't want it by their house. So I don't know. What do you think about that topic? I mean, I feel like this comes up all the time in many domains I work in between hepatitis C, HIV, and, addiction medicine. Yet if you told me where a syringe service program is, I have a phone number, but I couldn't tell you.
Right. I can see how a kind of knee-jerk response from someone who has no experience with addiction might feel like, why can't people just stop using? Anything that makes use safer or easier is just enabling it. And, if people wanted to stop, why help them use? But that's just it's just such an old-fashioned attitude. And it's anyone who works in addiction or has had an addiction or knows people who've had an addiction knows that doesn't really work. And there's no amount of dangerous or unpleasant that you can make drug use that convinces people not to use drugs. It's just, if it did, at this point, the threat is death and it can't get any worse than that. And even that doesn't dissuade people from using. The addiction is just too powerful. So I don't know why people are against syringe services. I guess they just have a vision of them as bringing things they don't want into their zone or neighborhood. But
I think they're awesome. Incredibly cost effective, right? I feel like we have a sick care system in the United States, and I think that these preventive services, like a syringe, like the safe disposal box. I mean, that's like $3. Hepatitis C is expensive to treat. I think that the price has gone down, but the blue book value of my Hyundai Sonata is significantly less than a treatment course of Epclusa or Mavorite. So I think that and a syringe service box is cheap. So I feel like we're going to have to start leaning into some of these more cost effective alternative options just because of how expensive our healthcare is here. And it's the right thing for our patients too, right?
Well, it is the right thing for our patients, and, we can't help people if they're dead, like, we have to help people stay alive, and come out at the other side of their addiction with their health as intact as we can make it, because I think a lot of people do eventually come out the other side and find a path to recovery and not using drugs, and it'd be really great if they didn't then have to struggle with HIV, hepatitis C, all those things.
Yeah. How about you? What did you read about this past couple weeks?
Well, it's not brand new, but I saw an article from a few months ago that's really been sticking in my mind, and I did want to share it with our listeners. It was about anoxic brain injury after overdose. And of course, as a doctor, you would imagine if someone stops breathing, they are at risk for a little bit of an anoxic injury. Um, but we don't really think about that as being part of the opioid epidemic, some of the sequelae of the opioid epidemic. So in the US, about 1 in 15 overdoses is fatal. So 14 people of those 15 survive their overdoses, but they're left with often with deficits in cognition, emotional regulation, impulse control, and self-awareness. And many patients are unaware that they're living with brain injury, like it should be treated like a traumatic brain injury after their overdose. And, if they have cognitive changes, it's probably obscured by all the drug use and the mental health challenges that they may already be facing. So it's not clear how the anoxia contributed to the brain injury or the brain deficits. But if you have problems in things like self-awareness and impulse control, that really makes engaging in treatment even harder. So it's like every overdose you suffer makes it harder and harder to behave in a way that will allow you to help yourself. So, John, do you see patients who come out of overdoses with cognitive deficits or anoxic brain injury? Do you have patients who you think are in that situation?
I have two patients that I know had serious anoxic brain injuries I take care of after their overdose. And, both are doing actually better than we expected. But you're right. I, I did knew the one patient only after their injury, and the other one I knew kind of before and after. And certainly the one I knew before and after, impulse control issues were a problem before. So it's hard to say if that really got worse. But it's not an uncommon thing for like a young, healthy group of patients that otherwise doesn't have any medical issues.
Right. Yeah, I've just been thinking about it. And of course, there's no way to kind of prove it, and it doesn't necessarily change treatment. But I have a few patients who suffered many, many overdoses, 10 plus, 20, 30 overdoses. And I realize I probably should be treating them like patients with traumatic brain injury, um, in terms of medications, in terms of what I can expect from them. And maybe some of them should go to like cognitive rehab, see if I can get them connected with some of the brain injury folks. It's just sad because, like you said, these are young people, and they have their whole lives ahead of them. So it's sad when they suffer a brain injury.
I mean, sidebar question, like how often do you find yourself like ordering like neuropsych testing in this population? I mean, I feel like we order that for older patients, and I mean, I've had a handful in this group. I've used it over the years. Is that a something you've done?
Well, I have occasionally, but it's been more often to sort out like complex mental health diagnoses. Patients with cognitive deficits, but I feel like this article made me think I should be addressing those specifically. I kind of assume, I guess it was a combination of trauma and brain injury, incarceration, heavy drug use, mental health concerns, all of that kind of came together to leave people with cognitive deficits. Um, and I hadn't thought about neuropsych testing because it's like, what would I do with that information? So I use neuropsych testing if I'm trying to like with mental health, I'm trying to treat. Um, but of course, I should be probably doing it more. That's what this article made me think of.
Yeah, interesting.
It's also tied up in many of my patients have so many accidents. They've been in multiple vehicle accidents, fights, construction accidents just through their drug use. So they have multiple head traumas as well on top of everything else. So a little sad, a little bit of a sad note. But I'm going to be on the lookout more for that kind of brain injury in my patients and really think about ways I can address it if it's impacting them.
Yeah, it's an interesting concept.
So, John, you ready to tell us about your article?
Yeah. So the article I did tonight, I think is a little bit of a change of pace, but I thought it was really interesting because this comes up all the time about our discussions about precipitated withdrawal. So the article is entitled Buprenorphine-precipitated Withdrawal Among Hospitalized Patients Using Fentanyl. And it's from JAMA Network Open from September 2024. So a little bit of background. As we know, buprenorphine is a safe, effective treatment for opioid use disorder. It's scalable under our current U.S. regulations to a very high level. Buprenorphine is a partial mu-opioid receptor agonist, so it may cause precipitated withdrawal when displacing full agonists like fentanyl or heroin. Traditional initiation patterns with like 2 to 4 milligrams of sublingual buprenorphine given 8 to 16 hours after last dose of opioid based upon CALS scales has kind of been our typical gold standard or kind of like classic model of initiation. And while this method definitely effectively alleviates withdrawal symptoms with low precipitated withdrawal rates for short-acting opioid users like people using heroin, oxycodone, hydrocodone, it's really kind of unknown with fentanyl. Fentanyl is its own different animal in every regard. It's basically incredibly a short half life in terms of kind of how long it lasts, but also it kind of has these fat soluble, muscle soluble properties where it ends up kind of leaching out for long periods of time after last use, making kind of initiation of fear precipitated withdrawal quite high. Many patients decline buprenorphine due to fear precipitated withdrawal. And it kind of leads clinicians to look to alternative options. And, kind of personally, I do inpatient consults at our hospital for buprenorphine for patients with opioid use disorder. And it is interesting. I think that I have noticed over the past couple of years as kind of fentanyl has kind of risen and emerged, this really is quite a concern for patients. And a lot of patients are actually asking for referral to a methadone program in lieu of kind of receiving the buprenorphine right now and then in hospitalization, which is kind of an interesting shift. That's just anecdotal from my experience. Recent studies indicate low precipitated withdrawal rates, so kind of 0.8% and 1.6%. So, it's probably lower than some people give it credit for, although its true instance is really kind of unknown.
Yeah, I agree with you. I've seen more precipitated withdrawal in the outpatient, just patients telling me they've gone through it. And I think, right, combination between the long-acting fentanyl that's everywhere and people don't know how long they have to wait and the availability of diverted buprenorphine. So many of my patients have tried buprenorphine on their own and given themselves precipitated withdrawal at home.
Hmm.
And I'm just hearing that more and more. Because I think before when people are taking heroin and oxycodone, you only have to wait 12 hours, 24 at most, and you can take your first dose. But fentanyl seems to be a little longer sometimes.
Yeah, and a lot of people jump onto that like first 8 milligram dose, and that's like the worst dose, right, for precipitated withdrawal. It's not really enough to treat, but it's enough to give it to you. So, what is the clinical question here? It's what is the incidence of buprenorphine precipitated withdrawal in ED and hospitalized patients with opioid use disorder? 2 is how do factors such as severity of opioid withdrawal, so your CAL score here, initial buprenorphine dose, body mass index, and urine fentanyl concentrations influence the risk of developing precipitated withdrawal. And then finally, what are the implications of precipitated withdrawal for patient retention and care? So kind of a little about this study here. So this is a retrospective cohort study of 226 patients. This kind of came out of Philadelphia, so 3 kind of urban academic hospitals between January 2020 and December 2021. And really, this was kind of like data extrapolated from the EHR. Participant inclusion criteria was adults with opioid use disorder receiving buprenorphine. They talk about initiation of either a traditional 2 to 4 milligram dosage or a high dose, which is 8 or higher milligram dosage for initiation in the emergency department or inpatient setting. One thing to kind of be aware of, I feel like when we talk about kind of fentanyl and drug source that, kind of where were we at that point in time? And kind of data from kind of drug supply at that point in time in Philadelphia showed that fentanyl was the primary opioid and it accounted for about 86 to 100% of opioid weight at that time frame. So just for your lens as you look through this trial. Exclusion criteria was low dose initiation with continued opioid use. So kind of people that are on an opioid already for a particular reason that were kind of doing that kind of low dose or kind of like, we don't use the word microdose, but kind of a low dose initiation protocol, like partial milligrams, people with missing CALS documentation, people that received IM buprenorphine, and patients with minimal withdrawal. So if you had a CALS score of less than 8, you were excluded. The primary outcome was precipitated withdrawal, and they kind of defined it here in this trial as a 5 or greater point increase in the CAL score within 4 hours after buprenorphine dose administration. Key variables examined were the CAL score pre-initiation, initial buprenorphine dose, body mass index, and urine fentanyl concentrations. And they did descriptive statistics for the precipitated withdrawal incidents. They tried this logistic regressions for odds of precipitated withdrawal associated with those predefined factors. And they did a sensitivity analysis for precipitated withdrawal, kind of trying to fill in the missing data gaps. They did like a best case and worst case scenario. So, what do you think about that design, Sonya?
I think it's a good clinical question. It's something we've all been thinking about. I know last time we went to ASAM, there were a bunch of lectures on precipitated withdrawal, what it is, how to define it. So it's a very important question for our patients going on buprenorphine. I think they did a good job with it being sort of a retrospective cohort study. I guess you'll get into how much of if there was any missing data. I just wonder about was there a lot of missing data in terms of COW score, or was the hospital where it's done, were they really good about documenting that before and after the initial dose?
Yeah, like spoiler alert, there's a lot of missing data.
Yeah, that's what I worry about. Not to insult our own hospital, but I just feel like the whole sort of buprenorphine initiation process, especially like in the emergency room, it can be a little bit chaotic. So I feel
Yeah.
like you might not have all the data you need.
So is this trial valid? The study was funded with the research grants from NIDA, the National Heart, Lung, and Blood Institute. The authors had financial disclosures from basically non-industry sources, NIDA, NIH, the Pew Charitable Trust Foundation. It was a moderately sized retrospective cohort study of 226 patients, so this lacked randomization, that didn't account for unobserved bias and confounding variables. The sample size had limited statistical power and was insufficient to identify small associations between the predefined variables of interest and precipitated withdrawal. So not quite the sample size they had intended for this, and that's what the statistical analysis and authors commented about. The study focused on patients in hospital or emergency department settings, which may limit its generalizability to other environments. So a lot of us are in the outpatient world, so this wouldn't kind of be in that setting. CAL scoring documentation was missing from 39.7% of participants, which significantly limits the interpretation of the incidence of precipitated withdrawal. They kind of ran a best case, worst case modeling to show what it was in terms of how that would affect it. And both incidences of precipitated withdrawal we'll get to in a minute. They're higher than you would expect.
Huh.
The trial did not provide data to differentiate between patients newly initiated on buprenorphine and those continuing their treatment. So basically, were they already on buprenorphine, still using drugs coming in, or was it just a totally new start? So that kind of is an important data point discrimination. The data did not enable normalization of fentanyl concentrations for urine dilution. So basically, kind of the biochem here of how the fentanyl was used for analysis wasn't quite right to kind of give a direct correlation there. So what about the results? So kind of this patient population, just to give you an idea where they started from, there was 1,577 patients with opioid use disorder on sublingual buprenorphine. That was kind of the base pool. They talked about initiation of 375 patients, which is 23.8% received the traditional or the high dose initiation. And they talked about 2, which is 5.3%, started at 16 milligrams, like a very high dose initiation. In the CALS assessment, 375 had documented CALS assessments prior to buprenorphine. 226, which is 60.3% included in the primary cohort, were based on the timely assessment. So that means 40% just about were missing CALS data after initiation of buprenorphine. So 40% of patients, we don't have that kind of precipitated withdrawal CALS score definition that we talked about here. In terms of urine drug testing, there was 170 patients that had urine drug testing results. 123 at 72.4% had fentanyl or norfentanyl detection, and that was included in a secondary cohort for analysis of that particular subgroup. In terms of the primary cohorts, I thought this was interesting because they actually kind of differentiate the two cohorts into a cohort that was containing the fentanyl, norfentanyl metabolite in addition to a cohort that didn't. So here's kind of the difference between the two. So the first group that didn't have fentanyl or norfentanyl, their median age was 38.6. They were mostly male, 66.4%. They were mostly white, 56.6%. And their CAL assessment was basically, the timing of it was 2.6 hours until CAL's assessment. compared to the group that had fentanyl or norfentanyl in the urine drug screen analysis, they interestingly had a longer test to buprenorphine initiation, so kind of longer lag time until they could kind of start the medication. They had higher rates of infection or overdose diagnoses, so they came in either with an overdose or basically an injection-related infection, so like a higher severity of illness. And they were less likely to have a planned emergency department discharge, which is a nice way of saying that these patients left AMA. So, and even inpatient, they were also more likely to leave AMA. So, this would kind of let me know that kind of the group that had fentanyl or norfentanyl, at least kind of this is how I would look at it. It seems like it was a sicker population in many regards. It sounds like a more severe disease because they were kind of presenting with kind of later stage findings. So kind of like serious life-threatening overdoses, kind of substantial infections, and their disease was interfering with their treatment more so that they were leaving the emergency department and hospital without receiving optimal care. So that is kind of something to keep in mind as we look further. That group seems more severe in many regards. In terms of precipitated withdrawal incidents, so for the primary cohort, out of the 226 patients, 26, that's 11.5% met criteria for precipitated withdrawal. And when they talk about kind of a CAL score change to a more conservative CALs, they talk about within 2 hours into the 4 hours. They said that actually kind of made it very likely as well. And there was a median change in terms of 9 points in the average CALs after kind of administration for the patients that met precipitated withdrawal. In the norfentanyl and fentanyl subgroup, 123 patients, which was 123 patients total, 20 patients, so that's 16.3% developed precipitated withdrawal after administration of buprenorphine. And they did a sensitivity analysis accounting for the missing CALs data. 26 of 365 patients at 7.1% were assumed to not have kind of precipitated withdrawal based upon that model. And so kind of the takeaway here is that very high rates of precipitated withdrawal, much higher than we would expect. When you look at the two subgroups, 11.5% for the non-fentanyl fentanyl subgroup, and then 16.3% for the group that had fentanyl or norfentanyl. So kind of much higher than what I would expect.
It's definitely higher, but I just feel like the missing cow score for so many patients is a big limitation. I mean, I guess the question is that maybe I'll get to this. Did they look at the people who didn't have a cow score and if they were different from the patients who did?
I did not see that kind of in the data unless I was like somewhere in the appendix looking at that group particularly, but that is a very interesting subgroup, right?
From your sort of gut feeling, let's say you're in the hospital and you're starting someone on buprenorphine, are you more likely to skip the second cow score if they're like doing really well or if they're doing badly?
I would feel like if they're like, this is just totally guessing. I mean, first of all, the nursing staff does the CAL score. So
Well,
I mean,
yeah.
I feel bad. But I have a feeling that like just how busy they are, I feel like they would skip it more likely if the patient was doing well, right?
Right. You take your dose, they say, "You feeling good? Ready for your second dose?" The patient says, "Yeah, I feel great." Are you gonna sit them down and drag out a cow score or not? Yeah, that would be my guess too, but again, just speculation.
Yeah, it's a good thought. I mean, I thought about that as well. Kind of factors associated with precipitated withdrawal. So the primary cohort, there's really no significant association between precipitated withdrawal and severity of opioid withdrawal before buprenorphine, initial dose of buprenorphine, or BMI. So that's basically kind of our standard non-fentanyl, norfentanyl subgroup. Really no association with those predetermined factors. In terms of the secondary cohort, the one that we're kind of have more of interest here, looking at fentanyl and norfentanyl usage. So people with a higher BMI, kind of as expected, had higher precipitated withdrawal risk. They talk about an unadjusted odds ratio of 4.29 or adjusted of 5.12. Fentanyl concentration, so higher fentanyl concentrations defined as greater than 200 nanograms per milliliter were associated with increased precipitated withdrawal risk. Kind of an unadjusted odds ratio of 8.14, an adjusted odds ratio of 8.37. And then withdrawal severity, there was really no trend for higher precipitated withdrawal with lower CAL scores. They talk about this linear trend for higher incidence with higher urine fentanyl concentrations, which was significant. So kind of like takeaway here, at least from this data, it would appear that there's an association between higher BMI, which does seem biophysiologically plausible in terms of the mechanism, higher fentanyl concentration, and kind of withdrawal severity to a certain extent. So the question here for this then is like, will this kind of help me in patient care? And, Basically, this study indicates that a fentanyl-contaminated drug supply and fentanyl's lipophilic nature associated with prolonged opioid effects. It does raise concerns about buprenorphine induction challenges that may discourage patients from seeking buprenorphine as treatment. And certainly, I do see this firsthand. So this scenario comes up very, very commonly. The study demonstrates that prior fentanyl use does elevate the risk of precipitated withdrawal in hospitalized and emergency department patients with opioid use disorder. It would seem theoretically plausible that that would be a similar risk to an outpatient presentation as well. Despite its retrospective design and data gaps, the study does underscore the importance of that, when we're counseling our patients about fentanyl use during pre-initiation counseling and buprenorphine induction, it is a little bit of a different animal, right? It has different pharmacology behind it and pharmacodynamics. It behaves differently. And I think that kind of patients need to be counseled kind of accordingly about what to expect if you're going to do an outpatient induction, even if you do everything perfectly, right? So if you wait the 12 to 24 hours, you wait until they start to go into withdrawal. This is still something that you might have to push through to kind of get a patient into treatment and to start on the medication. The study also kind of supports the proposed mechanism that, the fentanyl lipophilic nature and metabolite accumulation in adipose tissue really kind of are an underlying potential mechanism for this phenomenon of basically difficulty with initiation. So I don't know, Sonya, what do you think? Do you think that this changes your perspective that much, or does change anything you would do?
Well, again, I think the data is a little bit limited, but the rates are higher than I suspected. And I don't necessarily think it's because of reading this article, but I've started to discuss more with people like an outpatient low dose induction where they overlap the buprenorphine with the drugs because they are very scared of precipitated withdrawal as a way to avoid that. I have like a little outpatient flow sheet that you can do, um, like a 7-day overlap induction. And so I've started to find that more, I don't know, more relevant for more patients recently. So in that way, my practice has changed a little bit. How about you?
Yeah, I mean, this is really common now. I do counsel patients that this is a possibility, and basically, the one thing I tell them is like when they start to feel some discomfort with the first dose, the idea is you don't like back off, right? It's like I tell them you got to hit the gas pedal and push through it, and I feel like that them telling them that this is expected as part of the induction process. I do feel like it kind of helps mitigate a lot of that, and I feel like people are more successful in actually being on the medication the next week when I see them in the office. But I think if I wasn't telling them that, they might take that first like 8 milligrams and feel like maybe not full blown precipitated withdrawal, but not quite right, and then just stop, which is like the worst when someone does that like 8 milligrams and they feel bad, stop. Next day they do the same thing, like 8 milligrams, stop. I mean, I've had those inductions too that are really hard.
Something really relevant to precipitated withdrawal. I did a little poll on our social medias because if those of you who listened to our recent episode about kratom know that we kind of contemplated precipitated withdrawal coming off kratom with buprenorphine. And so I did a poll on our social medias asking if anyone out there had ever seen or experienced precipitated withdrawal switching from kratom to buprenorphine. And the only response I got from all my polls was, "What's kratom?" So that wasn't very helpful. Um, and the jury's still out on whether you get precipitated withdrawal from coming off that product. I also wanted to share some interesting emails we got from the folks at the Kratom Sobriety podcast. So another podcast out there focusing on folks in recovery from addiction to kratom. So really shout out to them. Their podcast is interesting. And if you have patients struggling with kratom use and they're looking for stories that reflect their experience and stories of success, I highly recommend it. Chris from the podcast wrote to us, and I'll quote his email. In most spaces, we can't have a rational discussion of kratom because of its tenuous legal status in America. The industry itself claims that kratom is non addictive, and any problematic use is like a form of self harm by irresponsible individuals. Advocates are united in widespread denialism and minimization of any kratom harms, all in an effort to try to keep it legal. It's like the opposite of drug hysteria, but a valorization of a plant that has legitimate cons as well as positives. This dynamic means many consumers can't make informed choices about using kratom as they are bombarded with information claiming kratom is akin to coffee. It is all natural, etc. Chris wrote an article on ways to make kratom use safer, and I'll include a link in the show notes and the link to his podcast if anybody is interested. And just, recently I had a patient come to me again with kratom use disorder. And he felt kind of stupid that he was addicted to this thing that all the publicity says is normal and natural and is just sold everywhere and everyone else seems to be doing okay with it. And he got addicted to it and he felt really bad about that. And so I pointed him towards the podcast for some stories of other people who struggle with this. So he knows he's not the only one who runs into this problem. John, have you had any more kratom patients since we last talked?
I have a couple. I have one lady. It's interesting. I got her, and she's been using kratom, and I got her old records, and this has been an issue for like 9 years. I'm like, man, she was on it before it was a thing, right? I was like, talk about like an industry leader here. She was getting treatment for this like it was like 8 years ago. I was like, man, she was on this thing like in the beginning.
Well, good for whoever helped her get treatment for it. Well, everybody, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno. CME support from My Cares. Produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.